Good afternoon, everyone. I'm sorry I have too many screens up at once. I hope everybody can hear me okay. I'm Robert Stiles. I'm the program director for Telehealth Rocks and the Can Do programs here at KU School of Medicine in the Department of Pediatrics. And we're really excited that everyone is joining us today for our second session in the Medical Complexity series, all under one roof. As most of you have already been doing, which I'm really pleased to see, please go into the chat. Given the number of people participating, we're not able to introduce and have everyone introduce themselves orally today, but please put your name and the role in the chat along with where you work. We've muted everyone today. You can unmute yourself when the time comes to ask questions. You can always ask questions in the chat as well, and we will be monitoring that and trying to bring those today's presenter. Gosh, I can't speak today sometimes. We appreciate everybody keeping their camera on. We understand sometimes there are reasons to turn it off with things going on around you, but that helps everyone to kind of see each other. And really the goal of this is to have it be really more of a conversation and a really, telementoring session where everybody works together. And one of the things I find the most from all of these sessions is that some of the advice we get from schools and some of the ways schools help each other with issues they see or with great ideas that they have for how to manage things. Some of the best stuff comes from you guys. So please feel free to share in the chat anything you have to share about what we're talking about or any questions you have or any issues you're facing. We will send out completion certificates for continuing education after all of the sessions are complete. There are 4 sessions, so we'll have 2 more after today. And like we said, the chat will be moderated, and we'll also review that and send that out along with any resources that are identified by our speakers or by you, those of you in the audience today participating. So please fill out the pre-evaluation survey link that's been sent. The link will be in the chat. We'll send that out again along with the materials afterwards. And we really appreciate having everyone here today. Next slide, please. So here's just the general format. This is following the ECHO format. So we're doing the introduction, which I know gets old, but nice to get things, set the scene. Then we'll have a didactic presentation. And today, of course, that'll be on assistive technology. And we do have a case today. We're really excited to talk about this case and use this as an opportunity to learn about use of assistive technology and other things related to medical complexity and time for a group discussion. Please, next slide. So our faculty and presenters for overall are Emily Goodwin, who is a physician at Children's Mercy along with UMKC and KU School of Medicine, Dr. Ryan Smith, who is at KU School of Medicine, and Dr. Dana Bakula, who also works with Children's Mercy. Next slide, please. So I will pass off to Ryan, who can go through the disclosures and get us started with today's excellent conversation. I hope everyone's having a great day.
Yeah, good afternoon, everyone, and thanks for joining. The speakers and the chat moderators have no pertinent financial disclosures. Next slide. So again, this is for informational purposes. We are not making specific clinical recommendations. We'll kind of broadly frame clinical questions in the case. But again, we are doing what we can to stay within the boundaries of bias and the educational setting. Next slide. So there'll be a mid-session survey that'll go out with the completion of this session to kind of cover the content and the structure that we had in sessions 1 and 2. And then again, looping back to what Robert said, if you haven't completed the pre-session survey, please do that. That gives us some information as to how to build better programs in the future. And we'll be providing these slides and the chat log and resources that come from our team, but also from you at the conclusion of the session, probably within a few days. Next slide. So we'll be looking today at assistive technology. I will preface that this is a topic that could take weeks of intensive review to scratch the surface. And so we'll kind of introduce the idea of assistive technology, some of the ideas that frame assistive technology for the young people that we take care of. And we'll use two particular technologies, tracheostomies and feeding tubes, to kind of represent assistive technology as a whole. Next slide. So these are our objectives. Again, just understanding some of the assistive technology that's out there, and how to kind of address medical issues with that assistive technology. So next slide. So again, this is the first time that we have completed a word cloud. I will say I still do have very strong emotions when I hear the term assistive technology. We're kind of curious for those people attending, what words come to them. And so Christy, I'm looking at the slide now. We'll post a Poll Everywhere link, and if people can log into Poll Everywhere and type in a word or a few words that come to mind immediately when the term assistive technology comes up. And we may be able to put that link in the chat if the link isn't working. Thanks everyone for their patience. Oh, it looks like we got it going. Okay, there we go. And I'll give another minute or two, another 30 seconds or so. Yeah, this is great. And I think, again, it gets to hopefully some of the things that we'll address within the content of this lecture. But assistive technology really helps us get to a lot of core functions, whether it's ambulation with wheelchairs, addressing things like hearing, generally the principles that we always want to apply in taking care of children with medical complexity, making accommodations, making spaces accessible. And then I see some feeding tubes, definitely one of those things that's very common, and hopefully everyone has had some familiarity with feeding tubes, and hopefully some of the content that we have moving forward will provide some more information. We have a lot about communication, and again, that's one of these incredible parts of education moving forward with children with medical complexity, is the different tools that we have, and these are absolutely fantastic. Any comments, Dr. Goodwin or Dr. Bakula, from what you see?
I think it's striking that we see a lot of those like specific assistive technologies coming up, and I think that's kind of just interesting, of like wheelchairs, feeding tubes, things like that.
Yeah, I agree. And I think that you can continue to enter objects in. We'll try to figure out a way to get the final word cloud out to everyone. But if we can move on to the next slide now. Okay. So again, there are a large number of different assistive technology. This is a very incomplete list here, largely organized by body system, pulmonary, respiratory, upper airway with tracheostomies and ventilators, feeding tubes, different varieties, the G, GJ, and G, different catheters to deliver, to draw out liquids and substances from the body, ventricular peritoneal and other shunts, different ostomies, different technologies to deliver medications, and assistive technology to help with ambulation. Next slide. So one of the most important things when we look at assistive technology generally is understanding what each particular tool is used to address. And so I think some of this may seem kind of obvious, but taking a second to pause and look at very specifically what each of these technology gets to. And it's very convenient because we did the word cloud. I think we got both these principles of what these assistive technologies will help us do, and then some of the very specific uses for each. So next slide. We can see here when we one of the critical and life-saving purposes of assistive technology, and one of those things that has really done a lot to improve quality of life and longevity in young people with medical complexity, is being able to overcome some obstacles to core functions. And this is whether it's breathing assistance from different grades of positive pressure, from CPAP to biphasic assistive pressure, trade name BiPAP, or ventilator. These are things that, again, help that carbon dioxide and oxygen exchange and help our patients breathe. Circulation and having that heart pump work appropriately, like a defibrillator, helping a stool, whether it's colostomy or ileostomy. So again, in the past, 30, 40, 50 years ago, like these things would ultimately land children indefinitely within the hospital, or just ultimately change their quality of life and shorten their life. And so the fact that we have a lot of these technologies is fantastic. A lot of our children that we all take care of together can go to school, can learn, can build all these skills. And being able to do some of these core functions is kind of critical to that. When we did the word cloud, we saw a lot about some of these activities of daily living. And I think one of those to pay particular attention to is mobility. And so whether it's a wheelchair, walker, for different levels of capacity, orthotics to address, again, some of these positional, some of these ways that we end up having gait, to even things like pencil grips and elongated straws. How do we eat? How do we write? How do we participate in the activities of school and daily life? These technologies also can provide a lot of benefit to providing necessary medical and life care. And so we can administer medications via our feeding tube, inserting cases via central venous catheter. For those children that suffer from cerebral palsy and similar type of muscular conditions, they may have quite a bit of spasticity, and something like an indwelling baclofen pump can just consistently deliver medicine. Things like the vagal nerve stimulator device can pick out seizures by elevation or depression in heart rate and kick in and the vagus nerve to blunt the amount of seizures and duration of seizures that we have in. And things like secretion management, if anyone is taking care of children with tracheostomies, there's a lot of secretions that ultimately need to be addressed. And the tracheostomy is one of these very helpful tools for achieving that. So next slide. So one of those things that I always hone in on with the residents and the students that I work with, and I think it's good for everyone that is exposed to young people and not so young people with assistive technology, is understanding for each of those technologies, why do they have them? And it may vary quite a bit. And that indication is really going to give you some sort of insight into if there's a problem, if we are doing planning, if we're building into our IEPs, why we have a particular assistive technology really helps how we interact with it. So a partial, both of these are partial lists for tracheostomy and gastrostomy tubes, but for tracheostomies, the need to have a ventilator for a prolonged period of time. We'll see young people who spend significant amounts of time in the neonatal intensive care unit because they are born early. They may have tracheostomy for that reason. Some of those patients will graduate from the need to have actual ventilator treatment, but they may have a tracheostomy once they get to school, just as an artifact, just as a precautionary need. Fragile airway, so we don't get too far into the weeds of medical management here, but if there's some sort of respiratory emergency, if there's a big tongue, if there's some sort of blockage in the back of the throat or on the vocal cords, the traditional way that emergency personnel will provide breathing is to put a tube, endotracheal tube into the lungs. And some patients do not necessarily have anatomy or have issues that kind of prevent that from really being an option. That may be one reason that someone has a tracheostomy. Aspiration protection, that is one of those things that for those that have cerebral palsy and a lot of muscular disease, again, that is a very common threat to life is aspiration pneumonitis, and aspiration pneumonia, inflammation and infection that comes from having stuff go down the wrong tube. And sometimes just anatomic reasons for being able to breathe appropriately, having that tracheostomy is really important. Gastrostomies, which is the preferred term to gastronomy. I gotta say that I use gastronomy too, so that's the term that you use, that's okay. And it's usually a little more in Europe than gastrostomy, which is a preferred term here in the US. But it's a good way for young people that we have that may not be gaining weight appropriately, that may have functional reasons, medical reasons why they can't swallow, or just because maybe they were in the NICU for quite some time, just haven't built the skills to swallow. And those are some of the patients that we see that end up having feeding tubes. And again, there's any number of different anatomic reasons. I have a patient that has two very distinct tubes, one that's a jejunal tube, one that's a gastric tube, and then someone that has a superior mesenteric artery syndrome, where one of the arteries kind of blocks the stomach and the first part of the intestine. And so you get, we will do venting on one tube and medicines, and then infusion of food via another tube. So there's all these different reasons that we may have tubes, and different ostomies, different assistive technology. Understanding why we have those is really critical. Next slide. And I had told both Dr. Goodwin and Dr. Vacula that I was going to pause between each slide to elicit questions. I haven't done that yet. Any comments or questions from the chat?
None that have come up yet, but please feel free to put them in the chat if you have questions as we're going along.
And we'll have a short question period depending on the timing at the end of my slides. And then we should also have some time to have broader discussion after the case. So here are some of the different components of a tracheostomy. You can see the different components of a tracheostomy that is cuffed here on the top right. And then you can see how the tracheostomy fits within the anatomy on a side view, a sagittal view. There are different sizes as you would expect. There are cuffed versus uncuffed, and traditionally we see a lot more uncuffed in our pediatric patients. There are technically different lumens, different openings. We tend to predominantly see single lumen tracheostomies in the children that we take care of. And those that see stuff kind of attached to the tracheostomy, those are things that may be worth familiarizing yourself. Speaking valves, one particular time in the past, the Moyer valve is a purple attachment that you may see that has kind of a mesh component to it, and it can help with phonation, with speaking for those that have such capability with their tracheostomy. An artificial nose, that the form that I most commonly see is it helps with humidification, and it may be kind of like a sided barrel that has a mesh on either side. And I apologize, we've been trying to keep to copyright as best as possible, so it show you pictures of each of those, but hopefully you can look at the terms in here and Google them and get a sense for what each of them look like. But I imagine a lot of people that are taking care of, have educated children with tracheostomies are pretty familiar with each of those devices. So next slide.
Right, and I do have a quick question on the
Yeah.
so with, I think those trachs, they can sometimes be scary if kids pull on them or mess with them or the strap comes undone. What are some of the big things that school professionals would need to be mindful of with the trachs and safety?
Yeah, I think it's a very good question. I think understanding that both at home and at school, there should be a plan for replacing the trach if it does become dislodged. A lot of the times, like at least at home and maybe at school, they'll have a size down that just makes it a little bit easier. Typically, with a lot of the uncuffed tracheostomies, they are somewhat easier to push back. But again, communication with the families, understanding like the risks for not having the tracheostomy in, understanding whether or not they're in a ventilator or not is a thing that changes stuff quite a bit. And again, a lot of this goes back to Dr. Goodwin's fantastic presentation on medical emergencies. Like hopefully with the tracheostomy, there's a pretty clear emergency plan provided. But one thing you need to ask yourself is whether or not a patient can be bag mask ventilated via the tracheostomy, via the stoma, via the opening in the tracheostomy, or in the mouth. And so again, If you do have anything like that, I think early communication with family is the best things moving forward. I will say that I don't have quite as many patients with tracheostomies as Dr. Goodwin has, but I'd say probably have 12 to 20. Emergencies such as dislodgement, especially for a stable tracheostomy, are exceedingly rare. But that's what we do, is we prepare, we prepare for the worst and hope for the best, and kind of just move things along. So that's a great question, Dr. Beck. I appreciate that.
Great, thanks.
So special credit to Dr. Goodwin, kind of a national leader on education around medical complexity. And part of her scholar's designation on the national level has been creating open source images for some of the technologies that we have. So if you look at your gastrostomy here, we can see in profile what a balloon gastrostomy looks like from the side. We can see here the balloon, the diameter, the distance all the way around, which is measured in French, and then the length. If you look over here, this is, of course, a gastrojejunal tube that has the element here that gives you the length of the tube into the stomach, and then the overall caliber of the tube here, which is 16 French. And if you just have a gastric tube, you'll have both the length of the tube and the French right there onto the tube. And so again, understanding that typically we're going to be using our gastric option to deliver medicines and jejunal option for feeds, and sometimes steady infusions of fluid is somewhat important. And we can see here where it lies here in this cute little baby. So we do have different types. There are balloons and non-balloons. I will say that the overwhelming majority are going to be a balloon gastrostomies, especially after initial transition period. For some length of weeks to months after the initial placement, they'll have a more traditional feeding tube, and then as long as everything is moving forward appropriately and the stoma, the opening is reacting as expected, then there can be placement of these balloon or non-balloon gastrostomies are a little more permanent and a little bit easier to manage. Next slide. So this is another thing that I think is really critical is, and Dr. Bakula mentioned it with the tracheostomy, is what can go wrong and how do we know when to escalate and bring in the medical team, the parents, the other team members are kind of critical for addressing it. A lot of it has to do with where the assistive technology is located, if it's internal within the body, if it's internal within the blood vessels or within some sort of cavity within the body. Anything that's internal to the body or internal to some of the blood vessels. So thinking about things like baclofen pumps, ventriculoperitoneal or VP shunts, central venous catheters, ports, things like that. Anything that's internal to the body has a pretty big risk of infection. And so fever, irritability, increase stress symptoms of the patient in general, things like seizures, confusion, irritability, those are things to pay close attention to. And when we're forming these IEPs, when we're having these conversations with the family and the medical team, it's important to understand, like, when we aren't feeling well, what happens? When like our tube isn't working, or do we throw up? Do we kind of have a full belly? Do we just kind of make weird phonations? Like, those are good things to ask. And and understand. Of course, with things more with catheters, than some of the other internal devices with assistive technology, you can have bleeding and clotting. Things like bleeding and clotting are by far the most common pretty shortly after placement of different technologies. We think about with like VP shunts within the first 30 days, infection and blockage and things like that are most common. And I think probably the most important thing beyond just kind of having this conversation with families as to when we're not doing good, how does it look, is understanding that when particular technology malfunctions, it can reveal the symptom that it's trying to suppress. So the idea would be, let's use epilepsy and seizures as an example. If someone has a VNS that's not working or a shunt that's blocked, it's not unusual for their primary symptom to be increased seizures, increased seizure frequency, increased seizure length. And so having what is normal, having how we look when things just aren't right is really kind of critical to addressing emergencies that may seem pretty frightening, but I think with a good plan and understanding for how each person is, shouldn't be too frightening. So next slide. We are joined by Dr. Lana Yoder, the pharmacist with the Beacon Medically Complex Clinic at Children's Mercy, to kind of possibly provide a little guidance on medication administration. But it's important to realize that conventional administration of medication is not an option for all of our patients. It's not as simple as taking a pill some of the time. And understand we can provide things via tube, specific things like pain control and chronic pain control patches can be really helpful. I know for seizure emergencies, rectal preparations of things like diazepam are used often. And due to the discomfort, I think, from working on that end, we are moving towards seizure rescue for things like sublingual administration of meds. For those that have catheter, indwelling catheters, there's intravenous, sub-Q, whether it's with syringe or via an insulin pump. That's a common method of administration. But understand, for every medication, there is a route of administration, and it may vary depending on the child's functional capacity and presence of assistive technology. Any other comments that you'd have, Dr. Yoder?
No, I think that really covers it. And I think one thing we've learned is to always ask, to even, especially with the kiddos with the gastrostomy tube, you know, are they putting the medicine in the G? Are they putting it in the J? Or what is their typical route? And sometimes the paperwork that you may get may say oral, but it would be really important not to assume that it's actually given orally, even if you see that written on the paperwork.
Yeah, and I will agree. I try as a complex pediatrician to make sure that those routes are always entirely accurate. I am sure that even I don't do it 100% of the time, so I can't stress how important that is. So thanks for that. Next slide. Okay. I think, again, this is titled Under One Roof for a reason. We're all working together to move forward the care, the quality of life, the experiences for our children. And I just want to kind of refer back to that great slide that Dr. Goodwin had in the first session that talked about that team for the child with medical complexity, the child and family being in the middle, but like spokes going out to dozens, if not hundreds of different team members that are involved in care for these patients. And so again, like communicating understanding when there's not clear information accessible to us via whether it's IEPs for those providers, or whether it's clinical documentation for educators, like doing what we can to connect. And hopefully this is a good opportunity to get together and have these conversations for how to best communicate and how to best kind of move forward care for the children that we take care of. Next slide. So hopefully this kind of captures what assistive technology is trying to do, highlights how important it is to communicate as an entire team. And I wish I could give you an exhaustive list of problems with assistive technology, but we definitely can't do that in one or even a few sessions or mini sessions. But hopefully some of the principles will kind of help moving forward with troubleshooting stuff in the future. Next slide. And then many thanks again to Dr. Goodwin for leadership, for providing education on care for children with medical complexity. These are resources I think are fantastic. We also will have a more extensive list that we'll provide out with some of our summary session materials. Next slide. And I would kind of move questions to the end unless unless Dr. Goodwin and Dr. Bakula see anything that's been kind of a common thread in the chat, but otherwise we'll shelf the questions so we can have adequate time for the case, since I went a little bit over.
I think I'm just seeing there's some questions about, you know, what kind of training is available for parents on these different types of medical technologies. And I don't know if you want to briefly touch on that before we go to the case, or save that to the end.
Yeah, I mean, I think it's a very good question. I will say that traditionally, a lot of the education for parents around assistive technology has kind of resided within the inpatient setting and around the time of surgery or introduction of assistive technology. We do have some great web resources. There's lots of great web and video resources. There's a great G2 video from Children's Mercy that is kind of parent facing. And so I think, again, for a lot of these technologies, there's pretty extensive web and institutional resources with parent facing, family facing, and provider and team member facing information. So yeah, we can, and Dr. Goodwin, I know, has looked into this a lot, so we can kind of discuss it maybe more at the end, so we have some time for the case.
And there was
Next
just
slide,
one other
please.
question
yeah.
about trends for, Juan asked, what's the trend for child medical neglect?
Can you clarify that? You said the trend for medical neglect?
Yes, that's what the question says. Juan, I don't know if you want to elaborate in the chat, please feel free. I can say, just from my own personal knowledge, there is data that children with disabilities are at higher rates, higher risk for abuse and neglect. So that's always something we just want to be cautious of. But if there's any additional clarification on your question you want to add, please feel free.
Yeah, and this is something I'll try to hit briefly because this is a very broad topic, but I will say that as mandated reporters in the healthcare setting and the educational setting, if you have a concern for medical neglect, reporting that to Division of Family Services is really important. It's very complex, and I even though I don't always, I think educators and healthcare personnel don't always see eye to eye with final decisions for Division of Child and Family Services. Like, they are really the experts in making more like clear determinations. And so if you have that suspicion, if you have that concern, I think engaging them is really important and providing them kind of information with as little bias as possible, with as little judgment as possible, and understanding that, again, like, this is hard. Like, I've had like colleagues that have had children with diabetes, which is so much less in complexity than what a lot of our patient families face with their children with medical complexities. And even that ends up being incredibly difficult and challenging. So like, yeah, it's a loaded thing. I don't know if I'll have time to discuss it. Maybe we can shelve that. I think it's an important thing and maybe try to bring it into another session, but it's a good question. Hopefully that helps.